I'll be introducing the lens and talking on my experience with AddOn. And we got a plethora of experts on all the different designs of the other lenses, and they'll be talking on that. And we'll have Dan Athavale giving the new adopter experience in his world. So if we look at this platform, and it's a combination of either hydrophilic or hydrophobic acrylic, and it's got a design that maintains good centration, easy to rotate, and is stable in terms of rotation. So this is the toric form, and you can see the two haptics, which can be compressed quite comfortably without decentration. And we've got the EDOF form, and Alison and Joaquin will be talking about that. And Banu will be talking on the multifocal design. So just quickly to understand, the Elon is a wavefront linking zone. It is a small central elevation which drives the wavefront on the anterior surface, and it's predominantly distance and intermediate. And we are using it more and more in the presbyopic population. The multifocal is a standout lens because of its reduced number of rings and very low dysphotopsia. And I'll be just talking about my 1stQ AddOn experiences, and I've been pretty brave in this field. So first of all, this lens is sulcus based, and a competitor equivalent is something like a sulcaflex. But the advantage of this one is complete rotational stability, whilst my issues with the sulcaflex in the past have been rotational instability. Sometimes even have to suture a haptic to an iris. Well, you don't have to do that in these AddOn lenses. So you can use it as many modalities. First of all, there's the multifocal, which is actually 6 rings instead of 7, and is just as effective as 7 rings in the bag. And a combination is the dual lens system, where you have a monofocal in the bag, and you've got your multifocal outside the bag for reversibility. But then you can add any power into the sulcus if you're doing refractive adjustments post-cataract surgery, and this can be a toric, it could be plus or minus powers, and you can get it custom made. Then we've got the SML lens, which is a magnifying system, an incredibly useful tool. I've done about 5, which is not a lot, but the dramatic effect and the advantages to the patients who have macular disease is very powerful, and we'll go through that. So there's the story on rotational stability, and I can promise you it is rotationally stable. I've never seen one rotate out of axis. And I've used the lens in the cohort where you think this patient is not suitable for a multifocal or borderline, and the patient has issues. They're thinking, I don't want to lose an opportunity of getting my vision completely independent, but what if? Or if they have a history of macular degeneration in the family, and you found 1 or 2 drusens and they're in their 60s, are you going to exclude them from multifocality for the rest of their life? So in those borderline cases, I will offer multifocal reversibility. And I've done at least close to 100 of those. Toric powers in the sulcus space, I will use in abnormal corneas, usually with irregular astigmatism. When you measure the astigmatism across different diagnostics, you can't work out the power, you can't work out the exact axis, and you're uncomfortable with using toric in the bag, because now what are you going to do? Change the whole system. So what I do, I reserve the toric power for outside the bag, because I can either rotate it or remove it and then put in another one. Then the magnifying effects I've explained, which is the SML. And the last one, managing negative dysphotopsia, I'm not talking about that because it's going to be in the scientific program in the 8:30 to 10:30 slot. So dual lens concept, two lenses, but it's a non-traumatic reversibility. If the person says, I hate these dystrophies, I can't cope, don't worry, we'll make you monofocal. And in the bag, very important, hydrophobic. Okay, we don't want hydrophilic in the bag because we know, Jared showed us, polypseudophakia with hydrophilics can eventually calcify. So we did 1 year data of comparing Liberty in the bag, Liberty and Liberty and Liberty toric versus monofocal in the bag and the add-on outside. And these two groups were compared over a year, and I had absolutely no difference in results. In fact, when I studied the positioning of the rings, you worry, if it's in the sulcus and the sulcus shape is slightly ellipsoid or not perfect, are we going to get a decentration of the rings? I never saw one decentration. So I'm very comfortable that when you put the add-on multifocal component in the sulcus and you set it on those Purkinje images, it will stay there. And the add is 1.5 and 3. And as I said before, the rings for the sulcus add-on is 6. Obviously, you have to have done your homework. We can't put an add-on in everyone. You have to know all about the zonular condition, and you need adequate pupil and adequate AC depth. And these are the toric ones that I looked at, which were in the abnormal cornea population. And it's there because I may want to change the toric. Or what happens if the patient comes to a graft and now we've got a huge refractive misalignment. How are we going to repair this? So you can go to the bag, outside the bag to the sulcus, and you get good results that way. So when we look, just remember these are abnormal corneas, so not everyone's going to be 6/6/20/20. And the 12-month data was very consistent in terms of good distance visual acuity. And we looked at the spherical equivalent. 75% were within 0.5 diopters, which is pretty good. And the refractive cylinder showed that we did correct the power, and we did well there. And if we look at the centroid of dispersion of the astigmatism on the left and what we landed up a year later, we have effectively corrected the astigmatism properly. So it's a very useful tool, and I would recommend it. So the SML is for stable scars. So if we look at vitelliform or a little bit of dry macular disease, but not someone who's got profound damage. And there are clinical indicators which we'll go through on how to choose this. So there's a 10 diopter zoom component right in the center, which delivers about 6 diopters of power at 15 centimeters. So these are the patients who've got reading glasses, and if they want to see something really well, they take the glasses off, and they'll bring the reading material to their SML eye like this, and they will scan, and they'll see a lot better. And they're profoundly happy. So this is how we do the workup. The best corrected vision in the better eye has to be somewhere between 618 and 660. But to be honest, it's usually 618, 624. That's the population I'm looking for. Patients read at 40 centimeters with their normal add, right? Then we take away all their glasses and their add, and we just put in a +6 diopter at the equivalent back vertex distance and say, now what can you read? And we bring the target to 15 centimeters. And if there's 2 lines or more improvement, they're a candidate. And of course, they all pseudophakic. So this is a gentleman who's 83. He has had a combination of dry and wet disease. And he's had his cataract surgery years back. And he's on injections, and he's getting more and more frustrated. So you can see the scar. on autofluorescence, and you can see the OCT shows there's loss of retinal cells and significant RPE atrophy. But he passed the test. So he was 618 pre-op. Post-op, he was 621, but with a minus 0.5, he was back to 618. So he did not notice a shift in distance vision. But his reading vision jumped. So he was N8 and binocularly N6 when he was reading at 15 centimeters, and he used it all the time. Then finally, the last one is the add-on plano lens to correct negative dysphotopsia, but that is for in an hour or two's time. So basically, I'm done on the add-ons, and I'm open to some questions now before we invite Joaquin up. Joaquin, you can come up now. Alison, please come up. Dan, Banu. So this is our distinguished panel with massive experience across all these lenses. And these are the people you need to ask questions to. Are there any questions on add-on? Gayatri.
Brian, thanks for showing the broad-ranging applications of the lens. One question, one comment. The comment is, with the anterior chamber depth, I'm sure you're not putting in many hypermetropic multifocals because of the ACD exclusion. The second thing is the UGH.
Yeah.
What's the incidence of that?
So that's a good point. And I think the design features stop us seeing UGH or UG syndrome. And the issue, there's no bolting, so it's a plano lens. And the point of touch is so minimal. There are 4 haptics with only just a minor touch to ciliary body, rather than a C-loop, etc. So I think it's pretty safe. I haven't seen one. Chris?
Can I add to that, sorry, Gayatri, just about the hypermetropic patients. Those are often the patients that are more likely to have a refractive surprise. And I agree with you that the anterior chamber depth in a phakic eye, 2.95, might look like you might not meet it. But it's surprising how much that anterior chamber depth will deepen after they've had cataract surgery. So in a pseudophakic eye, it's 3 millimeters, and that's from the epithelium, right? So that's usually you find that there is more than sufficient space.
Thanks, thanks, Brian. Very elegant solution for the 2 lenses in the bag. With your study with the multifocal add-on in the bag, how many of those patients did you were they unsatisfied and had to explant the add-on multifocal? That's one question. The second question: with 2 lenses in the bag, and we're doing surgery a little bit earlier for these patients, are you worried about extra tension on the zonules and perhaps dislocation later on?
Yeah. Okay. For a start, you guess how many I've explanted? 0. So that's the point, right? We shoving dysphotopsia in front of these patients who are anxious or OCD or may have a epiretinal membrane without traction, and we're worried, this is not the right thing to do. But at this stage, I haven't removed any. What was the other question?
Just the weight of 2 lenses.
Yeah. Well, let's wait and see. So in the literature, there's not a lot of late subluxing. I don't think I've seen one. But I've been following these patients up for now 6 or 7 years. I think we'll move on, and we're going to have Joaquin next. Joaquin is going to take us through EDOF profiles. He'll be talking about Elon and PureC and give us an in-depth study on optics.
Well, thank you very much, Brian. It's an honor to be here in Australia. I have learned a lot. I have fun a lot with all of you. So great, amazing the way you involve the attendees in this interaction. You are an example for worldwide of how to make this relationship between the speaker and the attendees. So thank you very much for teaching me this point. Let's go to the introduction of the partial depth of field, okay? You know that we published recently this global consensus around the functional classification, and recently we have this first meeting in Washington in the Congress of the American Society. Then in Copenhagen we achieved the consensus of the 4 big continental society: European, American, Asia Pacific, and Latin America. You have published in Journal Cataract Refractive Surgery. But only to take a fast view, we saw yesterday this classification. We have 2 big groups: the partial depth of field on the top, with 3 different subgroups. Would be the partial, very low depth of field, would be the monofocal. The enhanced, a little more depth of field, and the extended would be the EDOF. We don't call EDOF because it's a functional classification. We have to avoid concept coming from the optical bank. Focus is a concept coming from the optical bank, so if we try to avoid EDOFs, we move to an extended. And in the full, we have the steep, would be the bifocal, the smooth, and the continuous, okay? You can do this focus school with your friend if you want. Take a look. We have Nikki, would be the narrowed, only very low depth of field. We have Nikki with Alison, and enhanced. Then we have the extended on the top. And in the bottom, you can see the other group, the bifocal. Probably in the next picture, Nikki have to be in the end, or to be exactly a steep. We have then in the middle, the smooth and the continuous is very clear, okay? It's like the extended, but with more depth of field, okay? And I would like to make an exercise. Can you imagine enhanced lens with a little micro monovision, with the idea of increase a little the depth of field? Could you imagine that image? Let's see. This is. Okay, you have here an enhanced with a little micro monovision in order to extend a little the depth of field, okay? You can do with your friend. Let's go to Elon, okay? Let's go to see what are the partial depth of field, what are the optical difference of the lens. We have different technology of having this extended subgroup with smaller aperture, diffractive, refractive. We're going to see what the literature tells us about that. I really think that this is the spoiler. I really think that Medicontur managed, like nobody, this balance, perfect balance in between increasing the depth of field, reducing the photic phenomenon. This is quite unique because you can measure in optical bank, but the other thing is what are the outcomes in our patient. And this balance is very well managed by Medicontur. What is the magic of this lens? Take a look. We have this lens is, first of all, is refractive. We have to separate the extended, the EDOF, in diffractive and refractive, and this is refractive. We are going to see what are the benefits of this group of being refractive. These are the characteristics of the lens. And the most important for you to know of the lens is how they achieve the increase of depth of field. It's refractive, a space that you can see here in different curvature, in different area of the lens, in the center of the lens, and the linking zone that join the different curvature are the key to have this continuous depth of field. When we compare the profilometry of Elon with BBT, you can see the concept is quite similar, okay? The concept is quite similar, and the outcomes are quite similar in the literature. Let's take a look, for example, comparison with a new lens in this group, the Pure C. It's also the Pure C refractive. We have only one paper, you can see there the citation of Alfonso Bertoluzzi, and is a refractive profile, but this lens, the Pure C, don't use spherical aberration. It's a change of curvature. In the center, you can see it's a valley, and it's in the periphery, as you can see. We are comparing profilometry on the bottom, and in the top is not a profilometry, it's a map of power, okay? So it's not exactly the same, but we can compare. It's the only information that we have coming from this this paper. If you have some doubt about that, we can ask. But let's take a look to the most important. What are the clinical outcomes? So according to that, according to the classification, Elon would be a partial depth of field extended, as you can see. Take a look to the focus curve in terms of visual acuity. It's so smooth during all the defocus curve. Our sample, we published, and our sample were people very old, as you can see, and some of them with some comorbidity. So let's take a look to the efficacy of the intraocular lens. The efficacy of intraocular lens, as you know, have to be measured corrected and monocular. It's quite important for you to know, okay? And the different distances, avoiding this confounded that could be created. So let's take a look. Let's go to the corrected monocular. It's on the bottom. You can see the mean and the standard deviation is very clear. It's very tiny. So if you are going to implant this lens in your patient, for sure you are going to achieve these outcomes because the standard deviation is very low. And take a look to the accumulative, the postoperative corrected. Not take a look to the uncorrected, because the uncorrected tell you how good I am calculating the lenses of if I let them some micro monovisions and the focus. The corrected is very high to 2020, 87%. So it's quite amazing the performance for distance. Let's take a look to intermediate. Again, distance corrected intermediate. The mean 0.11 and very low standard deviation. There is not too much biometric factor that could affect to the performance, okay? It's quite important to know that. And the near vision, the mean and the standard deviation is also very low. So for me, the most important, this we are going to compare with other group, but the most important is they are nothing making noise, pupil, decentration, spherical aberration, that could affect to the performance. It's very consistent, this lens. Let's take a look, for example, you know our application, you have the QR code. Here, if you want to see all the literature, all the articles published in PubMed, you're going to see in our application, and you can make meta-analysis of everything of each lens, okay? So we made the meta-analysis of the 4 papers that appear in literature about PureC, okay? And we made this meta-analysis for distance, for intermediate, and for near, okay? Let's take the first view on the right. The distance is quite similar, as you can see, a little better to the PureC, but it's not clinical relevance, okay? The intermediate is exactly the same, and the near is a little better for not clinical relevance to Elon, okay? Let's take a look to distance, okay? And do you have, if you allow me? Yes? Yeah. It's quite interesting to see that. Let's take a look to distance. The mean of PureC is very, very consistent, very excellent. But take a look to 95% of confidence of interval, very tiny, and also the predicting interval. Predicting interval tell you the worst and the best possibility analyzing all the paper. The worst and the best, and very tiny. So this lens is very consistent. Exactly the same as us, okay? A little less, because take a look to this interval of prediction, okay? Let's go to the intermediate. The intermediate, you can see, 11 is quite similar. The confidence of interval, but take a look to the prediction interval. It's a little bigger, okay? So it's something making noise, some biometric parameter making noise here. And in near, it's quite similar. The worst and the best scenario, not in my opinion, it's not my opinion, it's analyzing these 4 papers. It's something making noise here. The prediction interval is around all these papers. So it's something biometric making noise here that it would be interesting to know what could be. And if you want my opinion, I could tell you, okay? So let's continue with the binocular contrast sensitivity. It would be quite interesting. You can see here, and the satisfaction and the independency. Of course, the independency, as you can see there, for NIA is not too high. We know, because this is the performance of this group, of the extended. This group is not made for avoid for the independence of glasses for NIA. It's for reducing photic phenomena, okay? So we are going to see that the prompts increase with the neuroadaptation of the patient. In the short term, at good, but in the long term, as absolutely incredible. But this is the key. This group has made to reduce the photic phenomena, okay? Let's see what happened with the photic phenomena with this group. It's quite interesting that we have to separate the psychophysic idea of this conception. This would be the photic phenomena, to separate or the psychometric. This would be the dysphotopsia, okay? What is the photic phenomenon? When you see a light, the artifact, the luminic artifact that appear, or the glare, okay, or the halo, or whatever, and you can measure with alanometer. It's quite important to know. And what are the psychometric? It's the dysphotopsia. How bother to your patient to measure this photic phenomenon, okay? We can measure not at all, slightly, moderate, very, and extremely. So take a look, because it's quite interesting, this paper that we published. The cutoff to go through, the cutoff to go through a slightly to moderate bothersome of the patient with the photic phenomenon is this cutoff that is you define for the light distortion analyzer, the OCAS or HD analyzer, the eye trace, and the pentacam. This is the cutoff, okay? So if your patient have in the preoperative this level, you are not going to increase the photic phenomenon and the dysphotopsia of your patient. It's quite interesting because it would be a screening. So having that in mind, the cutoff of pass through slightly to moderate is 15%, okay? Take this number in your head. Well, let's take a look to the literature. It's going to be published. We review the whole literature, and the EDOF would be the extended, okay? We have to separate the analysis on the literature, diffractive of refractive. Diffractive EDOF lenses reported more photic phenomena than refractive lenses. So this is quite important for you to know. In my humble opinion, according to the literature, the whole group of EDOF lenses has no future. Even some companies know, because in the past they had EDOF diffractive and they go to refractive. So this has no sense, this group. The future is going to be this extended EDOF with refractive technology. The cutoff of passing through moderate to slightly would be 15. The performance is good in diffractive, but take a look, the performance in refractive group is incredible, very low. But take a look to the Elon. It's even less, it's only 3%. Elon is in the incredible group of lens in refractive group that give to your patient lowest level of photic phenomenon. But after 12 months, after 1 year, of course, the neuroadaptation works and reduce the photic phenomenon in your patient. So this cutoff is an excellent performance to the Elon and overall in the long term. So in conclusion, the Elon stem depth of field is a partial depth of field extended. The patient reported is quite interesting to know that it's improved from 3 months to 12 months, and very few patients may report bothersome for photic phenomena at 3 months, but this reduced to 0% and 12 months. So probably this is my reference lens when I want to reduce the photic phenomenon with this balance with the depth of field and reducing the photic phenomenon to our patient. This is our application. You can see here. You can download our application for iPhone, iPad, Mac. You are going to have each paper that we publish in PubMed appear there. You can make meta-analysis, compare one category with another, one lens with another. You have to do it, download in your paper, and when you have a speaker, you have to see it's the outcome. It's exactly the same outcome that they have in literature. You have a free area, and the pro area is to pay it and go all the money to the Elena Barraquer Foundation that fight about preventable blindness in the poor countries. And finally, invite to our Congress in London in next September. Thank you very much for your attention.
Let's get Alison, because she's talking on clinical applications, and then we can start opening up to questions on the Elon platform.
Thank you, Joaquin, because I think as surgeons it's so important to be data-driven, and that now allows me to talk about sort of real-life applications and practical applications of Elon EDOF IOL. So we have a few clinical trials running, and I'm going to today focus on the retrospective trial because it's targeted to mini monovision. The prospective trial is just more limited and a bit stricter, targeted to plano. And it's binocular implantation, and I've used a toric IOL when needed. And the post-operative evaluation included at 1, 3, and 12 months visual acuity at distance, intermediate, near, including defocus curve testing and contrast sensitivity testing, residual refraction, and patient satisfaction or PROMs. So compared to the target treatment, refraction, the outcomes were very closely the outcomes were very closely bunched towards the plano. And remember that these were targeted to mini monovision, so there is a small proportion down in the myopic end. But really we're seeing at 12 months, 94% at plus minus 0.5. And remember that this is uncorrected distance vision and corrected distance vision in the darker colour. So for the corrected distance vision, we have 100% of eyes at 6.6 and 80% of eyes at 6 on 4.5. And for the uncorrected mini monovision targeted eyes, we have 94% at 6, 7.5, 88 at 6.6, and 100% of eyes at 6.9. So the defocus of the Elon EDOF, the defocus curve shows quite a broad range for this lens for the Elon, even though it's an EDOF. And this is the monocular distance corrected defocus curve, so it's quite broad at around 2 diopters. Looking at the intermediate and near results, and these are distance corrected results, we have 100% of eyes at N12 or better for intermediate, and 80% of eyes at N10 or better. And for near, the results are good for an EDOF, with 100% of eyes at N14 or better, and 93% of eyes at N10, N12 or better, and 73% of eyes at N8 or better. So that's quite useful because in the clinic you can show patients the vision chart and give them an indication of where they're likely to fall with their near vision. And then, of course, we're looking at mini monovision, so the intermediate and near results are even better, with intermediate 100% of eyes at N10 or better, and the same for near, and for near 93% of eyes at N8 or better. I'm now going to move on to the post-LASIK eye because this is becoming an increasing problem where we're going to be dealing with post-LASIK cases in our waiting room for cataract surgery. And these corneas are aberrated. We have challenges with IOL calculations. And these are the patients that specifically sought out spectacle independence, and they're not always suitable for a multifocal IOL. So in order to achieve spectacle independence, then an EDOF is a good option for them. And we have to remember that the world has changed. So this is 50 and 60-year-olds 30 years ago, the Golden Girls, and this is 50 and 60-year-olds now, as well as this. So we have to pivot and change our practice to what we were doing 10 years ago because the world is changing. And moreover, this is what people are doing with their spare time and in their retirement. So the average post-LASIK patient is 10 to 12 years younger than an average cataract patient when they present for cataract surgery, and they're more motivated for spectacle independence, and they have atypical corneal profiles. So as I alluded to earlier, there's more difficulty with the lens calculations. There's a higher chance of residual refractive error because achieving the target and the accuracy with the IOL calculations is more challenging. They're more likely to have visual quality issues and dysphotopsia. They're more likely to have dry eye because of their corneal keratorefractive work, and they can have weaker or irregular corneas. And it's not just a technical challenge for us, it's also a communication challenge, because often if they've had LASIK, then they've had that real wow factor, and you just have to temper that, because often they can be slower to recover after they've got a LASIK flap as well. And I really treat those like a corneal graft post-operatively. So now just jumping into 2 patient examples. Firstly, the post-myopic LASIK patient. And I'm just highlighting the spherical aberration because, of course, post-myopic LASIK, often we see higher positive spherical aberration. Of course, the cornea is usually positively spherically aberrated. And in this patient, the myopic ablation must not have been too high, and often we don't have the data. But it is still in the positive range, which is what you'd expect. So the reason I like using Elon for post-LASIK eyes is because it is neutral, and there aren't many neutral EDOFs available on the market, and most of them are negative spherical aberrating. So this patient had non-simultaneous cataract surgery with Elon, aiming for plano in both eyes. And the 1-month results in the right eye were pretty good. The near was much improved by 3 months with N6 and seeing 6 on 7.5 plus. And in the left eye, the near was pretty good, but we had a little bit of myopic astigmatism helping that. But the distance had improved by 3 months to 6.6 plus, with the near staying at N6, so that was quite pleasing, and that was a binocular result as well. For a post-hyperopic LASIK, and unless you're sort of accustomed with looking at post-LASIK eyes, it can be a little bit more challenging to tell whether they've had a hyperopic or myopic LASIK. And again, that's an argument for using a neutral spherical aberrating lens. This patient had a negative spherical aberration because of the previous hyperopic LASIK, so we wouldn't want to use a negative spherical aberrating IOL. So this is a 56-year-old emergency department nurse, very active. She had LASIK, ages ago, and as is often the case with hyperopic LASIK patients, had regression and enhancement. This was quite early on in the Elon journey, so we didn't have available the Elon for the right eye, so I implanted another lens, and the target was supposed to be for mini monovision, and I was aiming for minus 0.75 in the left eye. And the results were 6.6 for distance and intermediate N6 and near N5. And even though I had targeted minus, she ended up plano. And her main issue post-operatively, which we had to deal with, was the dryness, but she's thrown her glasses in the bin.
What kind of arts and crafts are you doing? Are you threading a needle?
Sometimes, on occasion,
yes.
Not that much.
Yes. So crochet,
I paint,
painting.
I do a lot of puzzles.
Yes.
And as in jigsaw puzzles with got lots of little bits in it.
Yeah.
So all of that stuff I'm completely free of classes from.
Amazing.
Yeah.
So often we think about post-LASIK patients as really only being suitable for multifocal lenses, but I would encourage you to think about using an EDOF because it's also a softer landing zone, and there's a bit more forgiveness in the target because of the EDOF effect. There is going to be a continued increase of post-LASIK patients in your waiting room, and with the right formula, and I'm not saying that the calculations are easy, but it's worth it to achieve spectacle independence for these patients, and with the right communication and setting expectations for the patients in case you're not hitting the target and you're more likely to need an enhancement, it is possible to achieve excellent outcomes. And Elon EDOF IOL. It offers a balanced solution, so you get that extended range of vision with reduced dysphotopsia and is really well suited to many post-LASIK eyes.
I would like to present our clinical experience with Liberty Trifocal IOL. Trifocal Biflex Liberty is a single-piece, foldable, aspheric, hydrophilic acrylic IOL with a UV blocker and blue light filter. It has 7 diffractive rings in the central 3 mm region, occupying 25% of the optical surface. Outer region with refractive properties, occupying 75% of the optic area. The anterior surface has an apodized diffractive optic, featuring a gradual reduction in step height from 2.2 micron centrally to 1.4 micron peripherally, optimizing light energy distribution and minimizing photic phenomena while preserving visual quality. And in the posterior surface in toric models, the cylindrical correction is up to 6 diopters. Most of the conventional trifocal IOLs contain 15 to 26 diffractive rings, and this means increased light scatter, greater probability of halos and glare. On the other hand, Liberty has only 7 diffractive rings, and this leads to reduced optical disturbances and excellent visual quality. And Liberty has a balanced optic material. The refractive index of Liberty is 1.46, and this is close to the crystalline lens, providing a natural optical behavior. Although a higher refractive index allows a thinner lens profile, it also means lower Abbe number and therefore a higher propensity for glistenings. Liberty itself has high Abbe number of 58, and this means less chromatic aberration and sharper retinal image and better contrast sensitivity. And it has stable biflex platform. Double C-loop optic architecture provides broad contact with the capsular back equator, and it provides excellent IOL centration, reliable toric axis alignment, outstanding rotational stability, and predictable refractive outcomes. Here, I would like to present the results of our clinical study with bilateral implantation of Liberty Trifocal and Trifocal Toric IOL. This study included 190 eyes of 95 patients. These were cataract or refractive lens exchange patients, and we followed up these patients for 3 months. Here we see the visual acuity outcomes. For distance, 95.5% of the patients had 20/20. For intermediate, this number was 83.9%, and for near, the number was 96.8%. And 100% of the eyes achieved more than 20/30 vision at distance and intermediate, and better than 20/25 vision at near. And we were able to achieve highly predictable refractive outcomes. Mean manifest refractive spherical equivalent was within plus minus 0.5 diopters in 86.6% of the patients. And the residual cylinder was less than 0.5 diopters in 65% and less than 1 diopters in 98% of the cases. Here we see the focus curve of the Liberty Trifocal or Trifocal Toric lens. Visual acuity remained better than 0. logmar from 0 to minus 2.6, and this provides a continuous vision at distance, intermediate, and near. And here we see the contrast sensitivity results. As you see, Under photopic conditions without glare, the contrast sensitivity was within normal limits at 3 months. Under photopic conditions with glare, still the contrast sensitivity was excellent. Same with mesopic contrast sensitivity without glare. However, in mesopic conditions with glare, we see a decline here at higher spatial frequencies as expected with most of the trifocal lenses. But still, the contrast sensitivity was within normal and functional limits. The spectacle independence in our study was 94.4%. These subjects needed no spectacles or contact lenses. And this photopsia was very low. Halos were reported by 31% of the cases. However, 88% reported that the halos were not bothersome. This rate was 22% for glare, and 97% reported no significant bother with glare. And 100% would decide to be implanted with the same IOL if they underwent the same procedure again. The patient satisfaction rate was high. And I would also like to present a real-world case. This is a 48-year-old male. The visual acuity was 20/20 at distance. He was ametropic, and this was a clear lens exchange patient. We implanted him with trifocal toric in the right eye and just trifocal Liberty in the left eye. 3 months later, the visual acuities at distance, intermediate, and near were 20/20, and he had complete spectacle independence. I would like to show you the contrast sensitivity results of this patient. Here in this small inset graph here, we see the preoperative contrast sensitivity, and this is the postoperative contrast sensitivity. As you see, under photopic conditions without glare, the contrast sensitivity was very good. There was almost no difference, and after surgery, even it was better in this patient. And this is the preoperative photopic contrast sensitivity with glare, and this is the postoperative result. As you see, the contrast sensitivity is within normal limits. And these are the mesopic contrast sensitivity results. This graph without glare, and this small graph shows the preoperative values. As you see, without glare, under mesopic conditions, the patient still had very good contrast sensitivity. But when we add glare to mesopic conditions, you see at high frequencies, high spatial frequencies, there is a decline in the contrast sensitivity, but it is still within normal limits. And this is one of the most important slides in my presentation, because we always associate this photopsia with trifocal lenses, and we forget even ametropic patients preoperatively might have this photopsia. We have given the quality of vision questionnaire to this patient, this questionnaire, before surgery, and patient reported glare, blurred vision, and focusing difficulties, although he had a clear lens and although he was ametropic. 3 months after surgery, we have given him the same questionnaire, and he reported only halos. And the halos, according to him, were mild and a little bothersome. So we didn't simply replace a symptom-free eye with halos. We actually exchanged some pre-existing visual disturbances for halos while providing full spectacle independence. Our clinical outcomes reflect the optical philosophy of the Liberty platform. 7 central diffractive rings allow low bothersome halos. Biflex double C-loop design provides stable, effective lens position and excellent refractive predictability, and high APPA material provides high contrast sensitivity and excellent quality of vision. Thank you.
That was excellent. So we finished with the official talks, and we got a good 10 minutes to engage with our panel. First of all, Joaquin, are you ever using the Liberty lens? Liberty, you use it?
Yes, this is my lens for full depth of field.
Right. So if someone wants complete glasses independence, you choose that lens.
Yes, we have to know that according to the literature, for having a full depth of field lens, the best technology is diffraction, because refraction to achieve the full depth of field would be for the cutoff point of 0.2 logma achieve more than 2.3 dioptries. You have to increase too much the spherical aberration, so you are going to damage the distant correcting visual acuity. So according to that, have to be a diffractive. This lens is diffractive. To reduce this photopsia and photophenomenon, you have 3 parameters. The pupil aperture, the bigger pupil, you're going to increase the photophenomenon, but you cannot choose the pupil in your patient. It's the pupil that the person have. The addiction, so for that reason, to what these trends of moving from trifocal to EDOF, but as we saw with an EDOF extended, it's not deep enough, the deep of field to near. And the third is the area destinated to the near vision. So having only 7 rings, you're going to reduce the photophenomenon in comparison with other option of having more area, okay? So the question is, but then this lens is very pupil dependent, not for the pupil that we used to have in our patient. In our patient, more than 55 years old, the more or less average maximum pupil would be 5 millimeter, 4.5 to 5. So in this condition, very big pupil, our patient could lose with Liberty 1 line for intermediate, but the performance in distant even improve, and in near keep. So it's, for me, it's a perfect balance.
Okay. And one more question to Joaquin. You've looked at the Pure C and the Elon, and they're very similar lenses, obviously wavefront, linked, one anterior surface, one posterior surface. And how have they performed, in your opinion, Pure C, Elon?
It's not similar, it's not too similar lenses. Both of them are refractive. This is a good news for both lenses, okay? They use, we saw, according to this paper, we don't put, I didn't see in any paper putting this lens in optical bends, only this paper, and we don't know the profilometry. But apparently, appears in the paper that Pure C wouldn't have a myopic chip with a small pupil that happened in all the lenses that use spherical aberration. Is this a good news or a bad news? We don't know, because we need more paper. But we are seeing something in the paper, this noise that I show you that appear with the prediction interval. Something is happening in the intermediate and overall in near. When do we have a small pupil in our patient? In distance or in near? Near, okay? If the myopic chip disappear with a small pupil, probably this is going to affect it to the near vision. Apparently, a good idea could diminish the clinical outcomes of our patient. This is theoretical. This is only our opinion put on the table. It's an excellent lens, but in my humble opinion, this myopic shift in small pupil is good for our patient to see.
So Banu, just looked at your data and the beautiful defocus curves, and that's one of the key things of the Liberty is the smooth defocus curve and continuous application of vision outcomes. Now, you had a few outliers there with up to 1 diopter sil or maybe even half a diopter of sphere residual. How do you deal with it, and do you always deal with it?
You're asking about residual sphere or astigmatism?
Both.
Both, okay. With the Liberty IOL, the refractive tolerance, in my experience, is high. So unless the astigmatism is very prominent, like 1.25 or higher, the vision is still very good. And if it happens, then we could do a LASIK touch-up.
So you feel it's a forgiving
Yes,
multifocal?
absolutely.
Right. So Alison, you've used so many lenses in your time because you are an early adopter. How do you feel about Elon in the current space of all the other EDOFs?
It's true, I think I've used every single lens, especially the EDOFs. Look, it is my go-to lens, and for a number of reasons. We've had good results, but the material and the technical side of things really does matter to me. And I'm often using a lens to match to the patient, and predominantly, particularly for the refractive cases. I'm not a one-size-fits-all surgeon, but the Elon is my basic go-to for a number of reasons, not just the results. So Banu alluded to the refractive index, and that's significant because in spectacles, a high refractive index material is great, but it's always combined with an anti-reflective coating. But we all know those patients where we can see the glint in their eye, or they ask about the glint in their eye, and that results from a high refractive index material, whereas the entire platform has a low refractive index, so we're not faced with some of those patients that would be really bothered by that. The ABI number we've discussed is very high, so it minimises the chromatic dispersion. The lens handles very well inside the eye, and that's not, you know, the defining factor why I would use a lens, but there are a number of reasons, but apart from the visual results.
Right. So now I'm going to ask Dan. He's a new adopter of these lenses. He was monofocal user and a young doctor in the regional. Now, there's some people in our chair who are thinking of going to a multifocal, and obviously your EDOF. What's your experience up to date?
So my experience was that the first advice I'd give to anyone who's young and starting on this journey and wants to pursue premium lenses in the form of EDOFs and trifocal lenses is find yourself someone senior like Brian and try and pick his brain. So my journey with the trifocal platform Liberty started about 12 months ago when I attended a dinner and had the opportunity to speak to Dr. Harrisberg and sort of learn what the criteria was for patient selection. I was a little bit sceptical because most of my practice is in a regional centre in Australia, and most of the patients do long distance driving, and I wanted to avoid things like glare, halos, starbursts and all the other things that we hear about. As registrars, we really don't get much exposure to trifocal lenses or the technology that's actually available and out there, but as patients were coming through, they did express a certain dissatisfaction with the fact that after cataract surgery, they were still reliant on their glasses, and a lot of the time it was simply because I realised I hadn't been offering patients more options aside from monofocal. I was quite afraid that I'd have to do lens exchange, they wouldn't be happy, and they'd be too symptomatic to actually get a benefit from these lenses. So after getting some advice from Dr. Harrisberg, I started my journey, and I started with about 10 patients initially. And my patient selection was very, very careful. I was careful to ensure they had a perfectly pristine cornea. They couldn't have had previous refractive surgery, of course. They had to have a healthy macula and a healthy optic nerve, and most importantly, they had to have very reasonable expectations. I think that was really the key. It is, of course, possible to try and determine how much glare and things people already have just by asking them, but even slit lamp examination, if they're unable to tolerate a simple slit lamp examination from glare, they may not be an ideal candidate for this lens. So after my first 5 patients, which were very carefully vetted and selected, and of course I was using quite a bit of help from the team at SurgiVision to pick the lenses appropriately to ensure I was getting good refractive outcomes, I found that everyone was very happy. And pretty much within 2 months, people basically said they didn't have any glare or halos or anything else. I was very careful to counsel patients on not driving too early in these regional settings where they might be driving 200 kilometres in northwest New South Wales. And sure enough, I found that they were driving in 2 days. And when I asked them about their symptoms, they really didn't say they had any. So the interesting thing about this was that the refractive predictability was very stable with good calculations. I think corneal topography is a must, and good quality IOL measurements and biometry. So if I had to, sometimes I'd pre-treat these patients with lots and lots of preservative-free lubricants as well as some steroids if they had underlying dry eye disease, and often repeated their measurements a number of times. So my journey started like that, and it's only sort of come along as I've gained more confidence in the technology and using it. So I think the biggest advice for anyone young who'd like to start on this is find yourself someone more experienced and ask them for help.
So let's open to questions, but Alison and I have to duck very soon for the scientific session, but you can mix and mingle and ask. Joaquin's got nothing to do, he might be playing golf today, I don't know what you're doing, Joaquin.
Alison, is it true or is it my wrong interpretation that with your Elon lenses, more number of patients got better near vision than intermediate? Is that right?
It is, and actually the intermediate results that we're presenting are probably better than what I'm presenting, and the reason why is we were using a near chart at intermediate, and so there's a crowding effect. So it's confounded the intermediate results a little, but it means that the intermediate results are better than what we're presenting here. Thank you for noticing that.
Okay, thanks.
I'm happy to say, in my experience, EDOFs, they always take something away. You cannot have perfect vision with a wavefront or a refractive change on the surface. So I find that, and I'm interested, 90% will deliver what they say, 5% will under-deliver, and 5% will outperform. And we don't know what that magic is. Joaquin, what do you think with EDOFs? Do they always present what you plan, or do you get outperformers and underperformers?
Honestly, according to our outcomes, it's easy to have a very consistent outcome, but of course, again, this type of lens is not for forgiven astigmatism or refractive error. A little more forgiven than trifocal, but again, it's quite important. For me, the literature, the evidence is giving us some information. As we said, the EDOF diffractive is something of the past. The future is going to be the refractive, all these things that we have made. One quite important thing for me, independent of the lenses in general, the cutoff point, we demonstrate with Liberty that the cutoff point of high order aberration need to be no more than 0.3 micron. This is a number to have on mind. If you implant in a patient with high order aberration bigger, above 0.5 microns, you are going to reduce dramatically the defocus curve. This is one of the most important. The second is we move to operate older patients because we are going to damage, not too much, but a little, the contrasensitivity. We demonstrated, we published that with Liberty, we achieved 0.8 unit or logarithmic of contrasensitivity. If your patient is seeing better, You're going to damage, of course. So it's better to wait till they have a little cataract with a loss of one line, because they're going to be very happy with that. We have to achieve a metropy for sure, and the dry eye. So it's not as much difficult. Everything is do it the right thing and explain adequately to the patient the expectation according to that. But if we operate in presbyopia, that they promise us, doctor, I don't use, this is the typical mistake. I made thousands of times. The typical hyperopic patient, that they don't use glasses. They promise me they don't use glasses. In distance, they have a vision of 0.6, imagine for near, even worse. And okay, for sure you don't use glasses? No, doctor, I don't use glasses, only for near. And I operate on them, and they are, after that, they were happy, but not happy enough. Why? Because they don't use glasses, but they have the progressive glasses somewhere. And they know what is too good perfectly. So let's wait till they have lost one line, because it's the perfect scenario to operate on.
Very good. Okay, so Alison and I are going to duck. I'm happy for you to carry on talking to the panel or asking questions. Thank you.